Okay, we're going to have three fantastic datablitz talks that are all related to suicide research. And then Tony Spirito, who's walking in, is going to offer us his reflections and impressions on what we should all be doing for the future of suicide research. And we'll have plenty of time for discussion. So excited to hear our first talk from Dr. Matthew Nock.
Thank you. Thanks, Mitch and Eric, for putting this together. Thanks for including me. I was really, really excited and honored to be asked to give one of these flash talks. And I thought a great opportunity to present some recent data from our research group. And so, Mitch, I had a plan to present 3 fire slides from our research group. I talked to Mitch a few days ago, and he said, maybe don't. We don't just want to hear sort of run-of-the-mill what you're working on. Can you give us, this is a forward-looking group. It's a friendly, informal group. We're among friends here. What are your thoughts about how things are going in the field and what's working, what's not, and so on? So I guess he didn't want me to share any of our data. And I take this as an opportunity to do a little bit of an angry old man rant and talk about the things that have frustrated me about this area of the field. There are some significant challenges that we're facing, and this is maybe an overly pessimistic view to some of you, and so I look forward to the discussion. I think the theories we have for suicide are overly simplistic. We have these 1, 2, 3 variable models that simply don't explain a large part of the variance in our outcomes of interest. Our designs and methods, I would argue, are overly simplistic. We're using largely cross-sectional retrospective studies with small samples, as Eric Murphy mentioned earlier. We're doing lab-based studies that are really contrived, these sort of made-up, artificial, attempted approximations of what's actually happening out in the world. Our treatments, I would say, have weak and somewhat inconsistent effects. And so our progress overall has been slow and in many ways stagnant. You may disagree with that assessment, as you are wont to do. As W. Edwards Deming has said, in God we trust, all others must bring data. And this being a data blitz, I brought some data on this point. So we recently, our research team did a meta-analysis on how have we been doing? What have we done over the past 50 years to predict suicide attempts, suicide death? This is I'll present a few slides from this meta-analysis led by Joe Franklin, who is one of Mitch's former PhD students, and a number of other people from our group. Effectively, what we found is over the past 50 years, the effect sizes for our predictors has not gotten better. We would expect these bars to be going up over time as we identify more powerful predictors. That is not the case. Why is it not the case? Because we've been looking at the same risk factors over and over and over again, literally for the past 50 years, using largely the same methods: self-reports, in-person interviews, cross-sectional studies. We also haven't been observing the behavior most of interest to us, which is in contrast to every other area of science, where we make advances by identifying some important construct and carefully observing it in nature. We haven't done that here. This is a map showing, or a chart showing, for longitudinal studies, how much time has passed between we measure our predictor and our outcome. And you see, for most of the studies, it's years that we're looking over a period. What percent of the studies look at the time periods for which we clinically are really interested? 0 to 30 days. 0.1% of all studies. So literally 99.9% of the studies in the literature haven't observed the outcome of interest and haven't predicted it over a clinically meaningful window. I see this angry old man rant. And our treatment effects are pretty weak. So we do have some studies, published studies, showing positive effects shown on the left here. So this is a funnel plot which shows sample size on the vertical axis, effect size on the horizontal axis, with stronger effects to the left, but you'll notice those are the smaller studies. As we have larger studies that more accurately represent the population parameter, they're centered around 0. For a funnel plot, you're supposed to see both sides forming a funnel. What you'll notice is there's not a single study on the right side suggesting strong evidence of publication bias. So people are doing studies saying, my treatment works worse than the control condition. Those either really coincidentally haven't been published, or our treatments aren't significantly different from 0. So what do? Fortunately, we've got the future of the field in this room today. So my want is that we focus on gaps in our understanding. We use new, non-traditional approaches to try and bridge these gaps, drawing strongly from psychological science, where we've made significant gains. And we do this with a sense of urgency and I would say short-sightedness. How can we try and make gains in the next 3 years, 4 years, 5 years? One potential path I want to talk very briefly about is the idea of digital prediction and prevention. And in a nutshell, what this idea is focused on is the fact that nowadays we're all cyborgs, right? We're all walking around with these digital devices, constantly capturing information in our phones and our watches and our emails and our social media platforms and so on. We have this digital information wrapped around us. We can use this to better understand, predict, and prevent. Here comes the data. So One big gap, and we've heard about this already, is we need methods for better combining information about risk factors. Eric talked about no longer looking at one risk factor at a time. We just heard a wonderful presentation on machine learning, and groups are starting to do this using large data sets. The figure here on the left is a study done by Ron Kessler a few years ago. The sample of 50,000 hospitalizations. We were talking just now, just before the break, about, well, what are good opportunities, tractionable opportunities for using machine learning? Suicide attempts, suicide ideation. The figure on the left, this is a sample of 50,000 people who were followed for 1 year post-hospitalization, really high risk time for suicide death. What this group did is use machine learning algorithms to create a risk score for each person and then follow them for the year. In the left is the top 5% of risk scores. That group included 50% of all suicide deaths over the next year. So this is a perfect example of how we've got data lying dormant in our health records. We can use machine learning to create risk scores for people, follow them prospectively, and get a better sense of who's most at risk for suicide. The slides on the right, the figures on the right rather, is a study led by Yuval Barak-Koren, doing this in a large healthcare data set of about 2 million people. The figure on the top shows how many years was a person in the healthcare system. Red is a suicide attempter, blue is a non-attempter. You see within the first year, you get pretty good separation. We know who's gonna make the suicide attempts. And the bottom slide, this is how many years, what does the risk score look like, how many years before the attempt? And we see about 2 years before the attempt, the risk scores really pop up. So we can identify about 40% of suicide attempts about 2 to 3 years before they happen with these approaches. And we talked about generalizability earlier. The study on the right, those methods were beamed to 5 other healthcare settings around the country, and the results replicated really nicely across these 5 sites, suggesting these approaches are generalizable. We also need better data on the real-time unfolding of suicidal thoughts, using smartphone tracking of people where we ping them several times a day to ask about their suicidal thinking. This is a study by Evan Kleiman. Shows if you follow 50 or so people, each box is a person. Horizontal axis is 1 month passage of time. Vertical axis is severity of suicidal thinking. We see that suicidal people are not all alike, and they seem to fall into these 5 different groups in terms of the severity and variability of their suicidal thinking. So we have these 5 subtypes of suicidal thinking that we can now try and better understand, and these results were replicated in a second sample. One could also use passive monitoring. So our group, other groups, this is with support by, with the UO one from NIMH, are using passive monitoring. We're using GPS signals in the top left. There's one person across 2 different days. The first day they're very active, the second day they're not very active. We can use that information to try and improve our prediction. The top right is call and text information. The bluer the box, the more calling and texting a person's doing. Each row is a different kid in the hospital. What we see is the more someone's calling and texting, the lower the risk of suicidal thinking that day. Using smartwatches, following people over time, what we're seeing, we're tracking electrodermal activity, heart rate, accelerometer. The values on the right are AUCs. For using yesterday's data to predict whether you're thinking about suicide today. EDA doesn't do much, heart rate doesn't do much. Accelerometer data, moving around a lot more, especially the night before, gives us pretty good prediction on your risk of suicidal thinking the next day. So we can use this digital information to inform our short-term prediction of risk. What do we do then? Use scalable interventions. So we should keep doing the interventions we're doing, 12-session, outpatient interventions, so on. They can be very valuable, but with digital methods, we can make progress much more quickly. This is a recent study by one of our grad students, Adam Jarzewski, where we, in 4 or 5 weeks, screened 40,000 people on a social media platform, found 1,500 that our machine learning algorithms suggested were at high risk for suicidal behavior. Those 1,500 got randomly assigned to a very brief automated bot-based intervention, which increased their risk of reaching out to a hotline by 23%. So totally scalable, totally automated. NIH, close your ears. Pretty cheap. We did it for virtually no grant funding. But in 4, 5, 6 weeks, you can do a large online scalable intervention. Not all these are going to work. A lot of them aren't. So now we tested it out. We don't no longer use those. Ones that work, we can iterate and scale up and combine over time. Thank you.